We hear a lot of them, but
So if they had just not commented on it, they would have been okay?
Correct.
Oh.
So when we have, and everybody knows Misty's list, when we have reviews on social media, make sure if it's not negative or you feel like you want to highlight them. Correct. If it's a good one, if it's a bad one. So when we have, and everybody knows Misty's list, when we have reviews on social media, make sure if it's not negative or you feel like you want to highlight them. Correct. If it's a good one, if it's a bad one. So when we have, and everybody knows Misty's list, when we have reviews on social media, make sure if it's not negative or you feel like you want to highlight them. Correct. If it's a good one, if it's a bad one. So when we have, and everybody knows Misty's list, when we have reviews on social media, make sure if it's not negative or you feel like you want to highlight them. Correct. If it's a good one, if it's a bad one. So when we have, and everybody knows Misty's list, when we have reviews on social media, make sure if it's not negative or you feel like you want to highlight them. Correct. If it's a good one, if it's a bad one. So when we have, and everybody knows Misty's list, when we have reviews on social media, we are going through and updating that this year, so we'll be changes that have been made, not big ones. Does anybody have any questions about this or comments? We are going through and updating that this year. All right, service overview. So these are Press-Ganey scores for everyone. 97 is good, 36 needs some work. As you can see the difference, the scores are pretty similar, but a lot of the other hospitals are included in the, I guess the pool of hospitals that Press-Ganey utilizes for these statistics have higher scores in the ambulatory area from the patients. So we're trying to constantly match and improve our game, and so are other hospitals. So in order to get those top scores, we really have to be anticipating and doing better and better and better and better. So you guys can see kind of comparison how good we've been doing. But these scores are honestly, like in the emergency room department, great job. That's the best I've seen it since I've been here. Yeah.
No, I just had a comment.
Sorry, let me go back.
On the ambulatory surgery,
yeah.
correct me if I'm wrong, but that includes surgical centers, not just hospitals, is that not correct?
I thought Eli fixed it, but he's not here to ask. But let me double check that, because we did recognize that as an issue. So we talked to Press-Ganey. I believe he talked to Press-Ganey about narrowing that down so that we can just have just other hospitals that have ambulatory surgery centers. And then I had asked to also narrow it down to critical access hospitals, but the pool they felt would be too small to just do that. So, but I'll double check and I'll get that back to you soon. And then inpatient, we've got a 72.3 and an 80.6. And does everybody know what a top box score is? I feel like we talk about it all the time and nobody ever explains what it is. So you know when you go to those surveys, you have 1 to 10. If you do the 10 or the 5, that's the top box score. It's the highest possible thing that you can give someone. So if they give it 4, it doesn't include in this top box number. Does that make sense to everybody? Okay. And I don't know if there's anything else I need to point out. Medical practice, we need to do better. Mike, you have anything you want to add on these? Okay.
Catherine, is that showing that all of our scores were down from last quarter?
Everyone, emergency department, yes ma'am.
So we are.
Yeah. And I do want to point out that the medical practice one, even though it shows down, they had significantly increased. So their down score is actually trending higher than the rest of the year has, if that makes sense. Vaping. Yay. Everybody know what vaping is? Anybody not know?
I think you should explain it.
You think you should?
I think you should explain it.
Okay, so vaping is the use of electronic cigarettes. I don't vape, so I don't have a lot of details on how the apparatus actually works, but I think there's a cartridge, right? And then I'm looking at Chrissy because I know she.
I
You did. You dabbled in it. Do you want to explain it for everyone? So you've got the.
Okay.
Because you've done it. So.
Okay.
This is Chrissy. I apologize for pulling her out.
Am I good now?
Wherever you want.
Am I good? Okay, so just to start off, to make it clear so it looks better than just saying that I was a vapor, I smoked for a long time. I decided that that wasn't good, so I switched to vaping. I made changes with the amount of nicotine in the juice, which I'll talk about in a minute, and was able to quit, and I have not vaped or smoked for like 5 years. So just to start that off, thank you. So as far as the vaping apparatus, so they have a battery and it heats up a coil inside of a cartridge. And so there's actually a juice that has some different chemicals in it that is actually heated up, and that's what actually creates the vape that somebody actually sucks out of that and into their lungs. So it's just a bunch of chemicals in a juice. And the juices you can find from pretty much anywhere, and it's not currently regulated.
Correct.
Which is actually where there's been a lot of issues related to what's being put in there, what's safe, what's not, etc. But that's how it works. Is it heats up that juice with the coil from the battery, and then it creates that vapor that people are breathing in. Any questions?
So thank you very much. Thank you everybody for listening on the spot. Sorry. So as it says, it's a $3 billion global industry, 600 plus brands, 8,000 plus flavors and liquids. The reason it's a big deal right now is, as Chrissy's personal story suggests, a lot of people have been moving to vaping instead of cigarette use because it's been marketed as a safer alternative. And we're finding that may not be the case. So these are kind of what all of them look like. I'm assuming the coil's in here somewhere, and you put the cartridge on the top. But like I said, I've only seen them at the group, like the gas station or something.
The picture of the one in white actually shows it super well.
This one.
This one.
Oh.
So if you see that metal piece in the center, inside of that is actually where the coil is. And then that clear part on the outside is where the juice is.
Cool. So lots of different designs. They all do the same thing. So the National Youth Tobacco Survey in 2018 had more than 20%, and I think that should say of, high school students currently using e-cigarettes, and it's an increase of 78% over 2017. And the CDC in 2018, 1 in 5 high school students and 1 in 20 middle school students are using e-cigarettes. Nationally, we've got 2.8% of adults in 2017 using e-cigarettes, and 6% of Wyoming adults are using e-cigarettes. Those numbers are a lot higher now, according to the CDC. The reason we're talking about it is because twofold. One, there aren't any regulations right now, so middle school students can go into the gas station and purchase these. And, well, in some states.
There's supposed to be 18 and above in all states. So there is at least that regulation because nicotine is a controlled substance. What's not controlled is whatever substances they're putting into the liquid. But every state does have a rule that the nicotine as a controlled substance is not allowed by anybody under the age of 18. Yeah, that is the one rule. But that's the only rule.
Cool. I didn't know that. And this is a great picture. So as of October 14, 2019, there's been 1,479 lung injuries associated with the use of e-cigs or vaping in 49 states. Alaska doesn't report their statistics, so we have no idea. 33 deaths have been confirmed in 24 states relating to vaping lung disease. That includes Wyoming, that includes this hospital. So we've actually had a death here because that's related to vaping and this lung disease. This is a beautiful, healthy lung. This is a popcorn lung. Does everybody know what a popcorn lung is? It's kind of gross. It actually, what it does is it damages the smallest airways that are within your lungs. It goes in, creates scar tissue, and then build up over time. And what you're seeing in these little popcorns are the scar tissue buildup and the damage that it's doing, and so it's slowly suffocating people. The other piece of this, do you know why it's called popcorn lung? I found this interesting, because I was like, what? I mean, it kind of looks like popcorn, but does anybody know? Because there's an additive to microwave popcorn that actually originated with this disease. So it's inhaled the smell of the popcorn. That smell is a chemical that causes this. So don't inhale too deeply with your microwave popcorn. The chemical is called diacetyl. Diacetyl, D-I-A-C-E-T-Y-L. If you want to look at your popcorn and make sure that it doesn't have it. Also, let me see, I'm just going through all of this just to make sure. There was a study that was done by the CDC in 2018 that tested 51 different brands of the vaping products, and none of the off brands that are currently causing some of this new lung disease that we're not there. The CDC still isn't sure what exactly is causing it, but they know that it's related to these off-brand vaping products. So of those 51 on brands, 39 of them tested positive for this chemical. So it's as dangerous as smoking cigarettes, just in a different way. They both have their own issues. So just to put that out there. So what do you see next? The other thing I wanted to point out is signs and symptoms of that lung disease. If you or a loved one do vape, these are things to look for and to contact your provider immediately and maybe go to the hospital. If you have had a chronic cough for over 3 weeks, if you have chest pain and shortness of breath, GI issues, so you're vomiting, you're nauseous, you've got diarrhea, like the whole Pepto-Bismol line, fever, fatigue, if you have all of those things, check it out with your provider, because these are the initial signs. Once you get these, the time between getting these symptoms and being hospitalized and possibly dying is like a week or 2. So it's really important to be careful and to look out for your people. Anything you want to add, Becky? Because I've asked Becky to research this a lot.
In the research I did, a lot of times it was the oils that the kids put in for like flavors and things like that. Makes it tastier, I guess. These oils go down and just settle inside your lungs. So the exchange of oxygen just gets less and less. So I just thought that was an interesting.
One of the pictures from one of the kids that got this actually posted on his personal Instagram and then started a movement. It showed the solidification of those oils, where it shows his lungs and like half of it is filled with this fat that's created from that those oils that they utilized. So it's scary. It's just scary. It's good to know about. So don't vape. Yay. Does anybody have any questions? I know that's a lot, but yes, Karen.
Are they teaching this to the?
So my understanding from Joel is that during the Thoreau Bailey thing, they did have a segment on vaping for the teenagers. And then Nona and Becky are also working on presentations in conjunction with marketing to see if we can do some rotations at the high schools or partner with the Department of Health. So yeah, we're trying to get the message out to the community. Because I know it's something, again, it's been like cigarettes were in the 60s, they were healthy. So, anything else? Yay! All right, Mike, ACO. You're welcome.
Morning again. How many of you were here last month when I talked about ACO? Do you remember exactly what it is we talked about? At least the main part of the topic. That was a while ago. You slept a few times since then. Do you remember we talked about, I promised you that as often as I can and am able to, I want to talk to you about ACO a little bit so you're familiar with it. The reasons for that is I want you to feel comfortable when somebody in the community talks to you about it, and you can give them an answer. And I want your support too. I need you to help me and support this effort. So that's the main reason I want to talk to you every month about ACO. So last month we talked about something called an annual wellness visit. Do you remember that? So in a few years, when I'm 65, and I join and I get a Medicare Part B plan, I'll come to the hospital to see my provider, and he'll do an annual wellness visit. He and the population health nurse, which is Ray Rushing, and others will help me get this annual wellness visit accomplished. So as I go through that annual wellness visit, that population health nurse is going to identify whether or not I have chronic conditions. If I have 3 chronic conditions, then it's going to be recommended to me to join something that's called chronic care management. And that way, Star Valley Health will be able to help me manage my chronic conditions, so in a way that will help me eliminate ER visits, unnecessary ER visits, will help me stay out of an inpatient stay in the hospital unnecessarily. If they help me stay healthy and manage my chronic conditions, then that's going to keep me out of the ER and keep me out of the hospital. Does that make sense? Okay, so let's talk about chronic care management today just a little bit. Patients with multiple chronic conditions. How many of you have a family member or a loved one that is over 65 that has that sees more than one doctor, or that sees multiple doctors? Okay, so let's talk about this piece of this. And this is called care coordination, and it's all part of this chronic care management program. So since we all know somebody who has multiple chronic conditions, and they're probably seeing many doctors throughout the year versus just one. So let's talk about that for a minute. Right now, we'll go through 2 or 3 different scenarios with you. Right now, PCP means primary care provider, or your family medicine doctor. And if you're talking about your doctor to your specialist. So these are some of the things that occur right now. Patients with multiple chronic conditions may see up to 16 different doctors a year. Wow, that's a lot of doctors. Specialist consults result in ordering duplicate tests 22% of the time when you're only seeing one specialist. So that's unnecessary duplicate tests. If we would coordinate our care better, we could eliminate those additional 22% of the tests. If you see 4 or more specialists, that's 43% of the time, almost half the time, the tests the patient get are unneeded because they've already been done somewhere. And that's really an alarming statistic to me. 25% of the time, specialist consultation reports have not reached the primary care physician up to 4 weeks after the visit. So our family medicine doctors that we go see, if you see a specialist or somebody over 60 specialist, that report, it takes so long for that report to get back to your family med doc. And then they're kind of in the dark until they're able to see what that specialist has told them. So now let's look at a different scenario. This is a hospital. So if I stay in the hospital, and this is how hospitals communicate to your family medicine doctor. 3% of primary care providers are involved in planning hospital discharges. Only 3%. This is a nationwide statistic. Hopefully ours is a little better than that. Less than 20% of discharge summaries were received in 1 week, and 25% were never received. Discharge summaries to the primary care provider. 38% of discharge summaries don't include lab results. 21% don't include the discharge medication list. 66% of the time, primary care providers treated the patient without having seen the discharge summary. So those are alarming statistics, aren't they? Just because we're not coordinating with each other to provide care to our patients. Now let's go to another one here. This is about the ER. So that in red is bad, that in blue is good. Just remember that. So it looks to me like about 30% of the time there is no medical history and lab results that come from the ER to the primary care provider. It's only about, how many steps do you think it is from the ER to our clinic? It's not very far. Primary care provider is not even informed of an ER visit about 30% of the time. That's a concerning statistic. Okay, now let's drill down a little more. Your family doc to you as the patient. 33% of family docs do not consistently notify patients of abnormal results in their tests. That's a third, 1 out of 3 of our tests, and we're not being informed of the results. 50% of patients leave the office without understanding what they were told. I'm not even 65 yet, and that happens to me. I'm getting pretty close, but so yes, that's half the patients don't understand what they're being told by their doctor. 2/3 of adults who've been hospitalized in the previous 2 years are prescribed new medications, but they did not receive information about resuming the medications they were already on before they came to the hospital. So a lot of people will just go home and say, oh, I guess I've got these new meds, I don't need to take the ones I was on before. So that's a grave concern too. So as you can see, we have lots of opportunities in healthcare, don't we, to improve how we take care of our patients. And that's really what value-based care and accountable care organization is all about. And this is as it relates to this chronic care management program. This is a busy chart, but it just really in essence shows that over here the United States is probably the worst in the developed countries and how primary care how many care coordination gaps there are from provider to provider and provider to patient. There's lots of coordination gaps, and we as a country do not do a very good job of that. So I want you to answer this question for me. Chronic disease and cost of care. Among Medicare fee-for-service beneficiaries, people with multiple chronic conditions account for what % of total Medicare spending? Now think about that for a second before you answer. I want to give you some information about what this means. How much do you think is spent by Medicare and supplemental insurances every year for Medicare patients? How much money? What's the total dollar amount? Does anybody have any idea? In the United States, how much money is being spent by Medicare and supplemental for patients?
800 billion.
That's really close. 800, Eli told me that. $840 billion. $840 billion is being spent on Medicare patients every year. So now, what do you think this number is? For people with multiple chronic conditions that are Medicare, what percentage of that $840 billion do they account for? 90% of that. That's over $600 billion spent on those people that have chronic conditions. That's amazing to me. That's just amazing. Okay, so I want to just to end this discussion, I want to talk to you a little bit about chronic care management, the program. And I would like to share with you how this works. So say I'm that patient that has 3 chronic conditions. And Ray calls me and he says, Mike, I really think you could benefit from being in our chronic care management program. And so I enroll in it. So what do I get for that? I like this. Ray is going to call me once a month and talk to me for 20 minutes. We can bill for that. As an organization, we can bill for that 20-minute visit and be paid for it. But Ray's going to get to know me, and he's going to get to know about me, and he's going to get to know what I eat, and he's going to get to know where I buy my groceries, and he's going to get to know if I need a ride to my doctor, or if I need information about services in the community I can take advantage of, like behavioral health or the food bank, or where I can get transportation and all of those kinds of things. Ray's going to have all that information to share with me as a patient. Really, chronic condition management, chronic care management, is more about social work with these patients than it really is about taking care of their health. That connection that a patient is going to have with Ray or Katina, who is another population health nurse at Star Valley Health, they're going to be able to develop that relationship in a way that will help these people that have multiple chronic conditions really survive and become healthier and eliminate ER visits and eliminate unneeded admissions into the hospital. So what do we get out of that? I told you last month, whatever we save Medicare, those savings, we get to share in those savings. So that's where it's beneficial for Star Valley Health. To keep people out of the hospital, we get to share in that savings. So that's how we take advantage of that. And above all, it's so good for the patients in our community to have that connection with us and for us to be able to help them. So anyway, thank you very much. I'll be back next time with some more information.
Chad with the financial update. Energy?
Energy.
You really did it the other month, so you gotta
All right. This is for the first quarter of our fiscal year, so this is ending in September. And those of you that are in the stock market, of course, into September is when earnings come out. And so this week is a big week in earnings reports. First quarter of a lot of financials, and so it is for us too in September. And so we have our first quarter out, and we had a very good first quarter. Our operating revenues for our first quarter came in at 22 million, just over 22.8 million. We budgeted 19.7, so we're 16% over our budget on our gross revenues. Our expenses were 5% over what we had budgeted on that, but that's still a small margin. We've done well at maintaining our expenses within being over our revenues. Our net loss here is, where's the red button on this thing? Very top one. There we go. Whoop. All right. There you go. All right, this net loss, net income here in September, we had $239,000 of net income. For the year to date, we're at $1,071,000. We budgeted $332,000. We've had a very good first quarter. In September, it was interesting, of this $7.4 million, we had a lot more Medicare revenue come in. So our patients in September, we had more Medicare patients in September than we've had the first 2 months. And so what that did is it caused more deductions in our revenue also, because we don't get, when we have Medicare patients, of course Medicare doesn't pay us as well. So we had to reduce the revenues that we had, or this number would have been even larger, because our commercial insurance pays us a lot better than Medicare does. And it was interesting that in September, our Medicare revenues were over $1 million more than the previous 2 months had been. So it was interesting that for some reason Medicare patients came in September more than they did the previous 2 months. So, but even with that, we had a good month with that. So our actual first quarter we're at $1 million, which is excellent here. Our operating income, if you remember, this is kind of a real first glance of cash generated, so we're doing well here in the first quarter, getting our cash up. We're at 61 days. We're still way below our 90 days that we're shooting for. That is 1 day better. I looked at the cash today, and when Sarah gets done with the cash, paying out payroll this week, after the taxes and everything, it's usually about 1.1 million that flows out after she's done. We'll be above the 61 days, which tells me we're in an upward trend to get that cash back up where we need to go. So it's going in the right direction, which is great. What was I going to say? Maybe it'll come to me later, hopefully. Up here on the statistics on our admissions, compared to last year's quarter, so this is comparing fiscal year 18 or 19 first quarter, we're 11% higher on our inpatient admissions to where we were last year. 18% on our surgery visits, our ER visits have increased 6%. Urgent care visits are up 18%. On this one, I wanted to let you know, when we're comparing this, you got to remember that the first quarter of last year, July through September, we were only in Alpine in our urgent care 3 days a week, whereas this year we're doing 7 days a week. So this 18% is large because of that, is a larger number because of that. Right now we've leveled off. So, so in our next quarter, we'll have better data because we've gone 7 days. For the next quarter, we will have data for 7 days for both fiscal years on that. Our clinic visits 18%. So you can see, compared to last fiscal year, we are seeing some growth compared to last fiscal year, which is great. So overall, we're doing well in our financials. October has slowed down, so it's great to see this number outpacing here, because it's always good to get above things, because you always have those months that slow down. It seems like for some reason October we've turned the faucet on. We are, and it's strange because last year October was probably our second or third strongest month, and right now it's going to be, out of the 4 months, it's probably going to be our weakest month, unless I'm not sure how the rest of this month's going to go out. But as of like yesterday, we're probably a little over halfway to what we budgeted, and we've got less than half the month left. So it'll be interesting to see how we finish out. And I'm not sure, Mike, if you've seen the surgery schedules and stuff, how we're doing. But for the rest of this week,
It's really busy for the rest of the month. Yes.
yeah. So we could pop out and have some $300,000-$400,000 days and get real close to budget. It's hard to say. It's hard to predict on how things are going to turn out. And then it could be another Medicare month. It's so hard to predict on some of these things. So thank you. We're doing good. AR days, we did jump up in the AR days, but that's due to some vacation, some volumes from the previous month, and some other concerns, some other issues, but nothing to be concerned about. That'll be able to get back down to a little 50. Any questions? All right. Thank you. Who's next?
All right. one of the things that we just added is we added a patient assistance fund. So as you know, right now we have the Jeans Friday where you can wear jeans on Friday, and then you can either do a payroll deduction with payroll, or you can put your cash in the jars that are around, and that money goes towards our employee assistance fund. So we've had a lot of patients that come in, and then we have staff members that are awesome, and they end up helping foot the bill for travel or for, I don't know, Chrissy, what are some of the things that come up that you see?
Patients who can't afford their medications is a big thing. So patients who they're waiting for their next payday or the next Social Security check, and they're prescribed a med right then and there for their admission, and they can't afford it. So, which most of you have probably seen me come around your different departments, be like, hey, I'm looking for money for a patient in need. This is going to be super helpful, so I don't have to do it anymore.
Yeah. So what we've decided to do is we have there's $1,000 that the hospital has put in there. It's available. And then we've just asked, you know, if you want to help with this, then you can, there's a payroll form in the back that you can do a deduction, or you can just, if you want to mark the money that you put into the jars for the Jean Friday, it can go now either to the employee assistance fund or it can go to the patient assistance fund. And those two funds will be kept separate, so if you want to continue just helping employees, you can continue to do that. Or if you want to help patients, you can also do that through this fund. So.
Can I do both, so I can actually have one Friday, or well, like double
yeah.
up? Okay.
The only thing we'd ask is that somehow you label it so we know where it's supposed to go when it comes into the jars. If it's a payroll deduction, it'll be fairly simple because we'll know based on the form that you fill out. So. And Sarah, I assume there's additional forms on the intranet. If you go to our HR page and then you go under forms, you'll be able to find the forms there if you want to do it that way as well. So, and then I need to do some updated training. So we recently did our rapid regulatory compliance, and as you know, there's sexual harassment training in there. But as an organization, we feel like we really need to work on our culture. And we really need to make sure everybody's aware of the expectations that we have as an organization as far as what we want our employees to do. So the first thing I'm going to start off by saying is we work in a professional environment, and we expect everyone to be able to come to work and expect that they can be in a professional environment. You shouldn't have to come to work and tolerate things that maybe you're uncomfortable with or that you feel are inappropriate, whether that's from vendors, from customers, from physicians, employees. We want all of our employees to feel safe and comfortable at work. Sexual harassment is illegal under Title VII of the Civil Rights Act. So of course we can't tolerate it as an organization if we know that it's going on and we turn a blind eye to it. That can be a problem for our organization. And again, we want to just make sure that everybody's comfortable at work and that they're not having to tolerate things that they're uncomfortable with. So let's talk about what sexual harassment is. It's defined as in quite a few different ways actually. So. And some of these, I'm not sure that our employees are even aware that this could be considered sexual harassment. So listen to this exhaustive list. Sexual harassment is defined as unwelcome sexual advances, requests for sexual favors, and other verbal or physical conduct of a sexual nature. That's kind of the obvious one, right? But it can also include sexual jokes and innuendo, verbal abuse of a sexual nature, commentary about an individual's body, sexual prowess or sexual deficiencies, leering, whistling, touching, insulting or obscene comments or gestures, display in the workplace of sexually suggestive objects or pictures, other physical, verbal, or visual conduct of a sexual nature, epithets, slurs, or negative stereotyping, threatening, intimidating, or hostile acts, denigrating jokes, and written or graphic material that denigrates or shows hostility or aversion toward an individual or group that is placed on walls or elsewhere on the employer's premises or circulated in the workplace on organization time or using organization equipment, including email, phone, text messages, or social networking sites or other means. So basically anything that happens at work that makes somebody feel uncomfortable or threatened in a sexual way, that could be considered sexual harassment. And so as an organization, we would ask that if that type of behavior is going on, that you stop that behavior. We'd also ask those individuals that feel like they've been around that and that they found something that's offensive, we would ask you to speak up. So if somebody's telling a joke and you're uncomfortable with that, we would ask you to just kindly advise that person to stop. And I think 90% of the time that's going to take care of the problem, and that's where it'll end. Right now, I'm worried that we have people that are just putting up with this and they're not saying anything to the people that they're offended by. And so then those individuals have no idea that their behavior is offensive and they're just going to continue to do it. And then we'll have people that have to continue to just feel like they just have to tolerate it. So speak up if you will. That will really help the situation. If you're uncomfortable doing that, you can always come and talk with me or your director. I would be happy to listen to any complaints that you have, and then we'll do whatever we can to address the problem as quickly and as efficiently as possible. We'll maintain confidentiality as much as we can. Of course, if there's an instance where there's only 2 people involved, that's a little bit difficult for us to keep the confidentiality as we talk to those individuals. But one thing that we will protect against is any type of retaliation. So if you bring a good faith complaint to us and we investigate that, and then we talk with an individual regarding their behavior, and then there's any form of retaliation back to you as an employee, we're not going to tolerate that as an organization. So make sure that, I think the big thing is just keeping the lines of communication open and also kind of setting those expectations. And if you're comfortable, we'd ask you to advise those individuals that maybe you're sharing jokes or comments or things that you're uncomfortable with to just stop them, and then hopefully it will take care of it. And again, emphasize the retaliation piece. We will not tolerate any type of retaliation. So, any questions? That's kind of a mouthful, but I want to make sure everybody's aware of it and knows that we're not going to accept it as an organization. So, open enrollment this year, we are going to be doing it on November 11th. And I'm quite excited this year as we've reviewed everything so far. It's looking pretty favorable for us. So our medical and dental rates look favorable. I don't think that we'll even have an increase on the medical. I know on the dental that there's actually going to be a decrease. So yay for that. Dental, we're actually going to be switching carriers. So we've been with Lincoln for quite some time. We asked our broker to run a disruption report. That's basically looks at the network to make sure that we're not seeing a lot of people that are going to have challenges with the network. It looks like it's going to be a pretty even move for everybody, that we're not going to see a lot of disruption. And we'll see a lower monthly premium. And there's also a couple of added benefits to the dental in that the dental will now, starting January 1st, it will allow any dependent up to age 26, even if they're not a full-time student. So that's a very positive change for us. Another very positive change is that the annual maximum for dental is increasing from $1,500 to $1,750. And then we've been able to have them add fluoride treatments for adults, not just children. So a lot of positive changes with moving to a different carrier for our dental. Of course, whenever there's changes like that, there always is, there's a potential that it might be a little bit different or uncomfortable for people at first, but I really think this is going to be a good positive change for you as employees, and the premiums are down and the benefits are up. So that's very positive. And then in addition to that, because we've signed up with AXA, they actually help cover the cost of part of our EAP. And they're going to add some different tools to the EAP that we haven't had in the past. And so they're adding a piece that will help with estate guidance. So you can contact them, and this is January 1st, correct, Sarah? That'll be effective. And they'll help with like will preparation and a basic last will and testament, which is really helpful. And then they also have some resources available for identity theft restoration, which that's great because all of us are going to probably experience that at one point or another. So thanks to all relying so much on electronic systems. So any questions on open enrollment? It's from 6 to 4 on that, 6 to 3 on that day. So please come and we'll help you get signed up for your benefits. And yeah, we're really excited about this year and looking at making some more changes to the medical that hopefully will be positive. We haven't got those completely ironed out yet, so I don't want to promise too much there, but I can at least say that our rates are not going to go up. So. And then our new hires, I want to welcome each of these individuals if they're here. We've hired Daryl Yemain in the lab. We're very glad to have him. That was an open position for I think almost a year, maybe a little bit longer. So very glad to have Daryl here. Claire Holden in Environmental Services. Kelsey Werner is an RN on Med-Surg, and Kelsey actually came back to us, so she's a rehire, but we're glad to have her back. Shelby Peedler, CNA at the Care Center. Cindy Clark, an Activities Aide in the Care Center, and I also believe Cindy is a rehire. And then Giselle Fry is a CNA at the Care Center. And Riley White in Environmental Services. So as you're out and about, is Riley here? Riley, welcome. Please welcome these new folks and help them feel comfortable at Start by Health. And then here is a list of our open positions. And then just a couple of quick announcements. So the community blood draw will be on October 24th, 12 to 6 in the Grays River Room. The Years of Service dinner, that's always a great event, is on November 6th. That will be at the Athens Civic Center, and if you're involved in that, you should have received an invite. And then again, open enrollment. And then our next all-staff meetings will be December 11th. And we'll do the same times, 10, 12:30, 3, and then December 12th at 5 o'clock. So, great. Well, we appreciate you all being here. Pam, I think we have a... Randy Wolfley. This one can't be right. Kyle Roniger. And then Megan.
One more quick announcement.
The breakfast,
Holiday breakfast.
holiday breakfast is December 6th.